Hi, this is Don Vibert with ImageWorks. We recently caught up with Dr. Edison Louie. Dr. Louie is a customer of ours, put in a cone beam system about 2 years ago, and he's going to give us a quick overview of his experience with ImageWorks, but more importantly, a number of specific examples where the cone beam has really made a difference in his practice. I wanted to provide a quick introduction to Dr. Louie. He's been practicing dentistry for well over 40 years, very sharp guy. Little known fact, he was actually the valedictorian of his high school class, so he's no dummy. But we hope you enjoy it. How are you?
Everyone's vaccinated. Practice is going, running smoothly. The cone beam's running smoothly, and
Beautiful.
the support that we've needed, you've given us great support.
Yeah.
So we're happy with that, and love the cone beam. It's done amazing things for our practice, and we've just explored all the applications, and it never ceases to amaze us what we find in a cone beam.
Yeah.
Compared to the preview off a regular dental radiograph, it makes the dental radiograph so insufficient. It's a glaring contrast.
Right. And I was trying to remember, and I should probably know this, but so had you had much experience with the cone beam, with cone beams in general before we started working
together? Yes, I was considering getting a cone beam probably, I don't know, 5 years or more ago. Yep. Probably longer than that. 5 years probably before I picked up this cone beam.
Right.
And I decided to buy a scanner instead and use the cone beam that the oral surgeon next door bought. He bought it. We would have bought it at the same time. And he said, when I told him that, he said, "I am so happy you didn't buy it. You can help me pay for mine." So I've just been referring them all over to him because I figured, I don't think I need a cone beam. And then it turned out my Panorex was starting to break down. So I needed a new pan.
Yep.
And then they said, unfortunately, you're going to pay a lot for this pan because you're going to have the guts of a cone beam. And you'll have the most expensive pan.
Yeah.
I go, oh no, and then so when I looked at it all, I said, well, it makes sense for me to go ahead and get the cone beam now, although I didn't really want to pull the trigger on it. But when I really thought about it, I got excited.
Yep.
And I could see the applications. I said, I'm going for it.
Yeah.
And I never looked back. It was really a good move.
Yeah. So tell me a little bit about, if you had to, just some of the examples of, how has it helped you? Like, what are some of the examples that it's helped your practice, helped your patients, helped your workflow?
Okay. My general practice is so expanded since I've been in practice, 51 years.
Yeah.
So it helps me in my ortho. When I do my ortho, it helps me in my pinhole surgical technique for gingival recession, because it helps me really, really definitively locate the mental nerve. I do a lot of bone graft extraction, implants, ridge augmentations. And so obviously to get a true 3D view of all this is so important, especially for, just understanding pathology, exactly where the pathology is. And I have some examples in the cases if I get a chance to show them to you.
Yeah, that'd be great.
Where on the radiograph, it really wasn't definitive, but it was questionable. And then we did the cone beam and we were shocked.
Right.
And so it really allowed us to delineate the extent of the pathology before I went in surgically.
Yep.
It really helped me for like implant placement. Although, I did a lot of the implant placement without cone beams and was very happy and successful with it.
Yep.
Fortunately, cone beams came along and I incorporated it at the right time. Because one case that comes to mind, I looked at it. It was a simple maxillary anterior incisor, had plenty of room on the radiograph.
Yep.
And then I thought, well, let me look at this carefully again. I just have a funny feeling. Let me look at this on a cone beam. I can't remember whether I did the cone beam here in my office with your cone beam or it was before I purchased and had it done elsewhere.
Right.
But when I looked at it, I was so happy I did, because what happened was the tip of the apex of that tooth that I was going to take out was against the buccal or the facial plate, and the plate of bone kind of looped around underneath the apex and then went, toward the lingual and then went up. And so, I would have been unhappy if I had a perf there.
Yeah.
Worked out really fine.
Yeah, well, it's funny because I would say one of the things that we some of the offices so many of the offices we work with, I would say a common theme that we often hear, and sometimes it's even, I wouldn't say it's a surprising outcome because it's not that, because, there is an expectation, but I think there's a sense of, all the advantages of having all the additional information, but from just this aspect of no surprises. You're starting a procedure, you're starting a surgery, and oh my gosh, there's information you weren't aware of, and you're in mid-procedure, and just that aspect of just reducing the risk across the board, making sure there's no surprises. That's a theme we've heard from so many of the doctors we work with, and it kind of sounds like you kind of feel like the similar
yeah,
theme.
that's so true across the board. Another thing I'm sure all the other clinicians have found is you may be suspicious of one area, and you want verification and validation through the cone beam, and you do get that in that suspicious area, but then you look around and you're shocked at what else you found.
Yeah.
And on totally asymptomatic situations.
Right.
And so that's always a shock to go back to the patient and go, look what we found on the cone beam.
Yeah.
And I explained to them that the dental radiographs have been our gold standard for so many years, but now came along the cone beam, and that is the new gold standard. And we're really surprised at what gets hidden in the compression of a 3D object in a two-dimension picture for a regular dental radiograph. It hides so many things, and they're totally understanding and appreciative of the fact that we have a cone beam.
Yep. And it's funny because you bring up another good point that's, I would say, is one of the other themes we hear a lot, is sort of this aspect of the communication with the patient, which is, as dental professionals, they look at a radiograph, even a 2D one, and obviously there's a lot of information they glean from it that a layperson, a patient, may not obviously see those similar things, and that sometimes, especially if they're asymptomatic, sometimes the cone beam is actually showing it in a way to the patient that actually makes it very compelling to the patient. And again, especially when they're asymptomatic, there's really no other trigger for them to feel like there's a problem, and that sometimes the cone beam is just simply from its communication value, that there's a lot of, that is just also sort of just, there's no convincing that, many times there's not really convincing that's required because the patient can see it for themselves.
Right. Yeah, it stands on its own. And, first I would have everyone come back here and I'd show the patient exactly what I found on the cone beam. And then after a while, unless it's a specific case, they just take your word for it because they know that you're so thorough and you feel so comfortable with what you're doing. Right. But if it's really unusual, I like to show them too if I have time. I go, let's look at this together. And it
absolutely.
And it also I think they can appreciate sometimes the limitations or limitations of surgery. Like I've got one case I was going to show you. It looks good. It doesn't look that bad on the X-ray, and yet it was so infected it blew out both the buccal and lingual plates.
Wow.
So then after seeing it that way, they can truly appreciate all the challenges we have in surgery to rebuild that, and how important it is for them to leave that area alone while it is healing and forming new bone.
Yeah, absolutely. Well, that's great. And so out of respect for your time, what I'd love to do is maybe before we shift over, and maybe we could shift over, and I know there were some things you wanted to show us. Maybe what are your thoughts on working with ImageWorks? I mean, how obviously there's lots of options out there, and clearly all kinds of pros and cons. And I'm just curious if you had any thoughts on who are the folks that could value from working with ImageWorks.
I think the cone beams. I think first of all, there are probably a lot of clinicians out there that aren't familiar with cone beams, and if they had an inkling of all the different applications, they would be so excited about it. And I know at first, let's take a typical case where there's a relatively new doctor and he's sitting there going, "Oh, just the last thing I need is a new bill, more overhead." And yet as soon as they can afford to get their foot in the door and start using a cone beam, they'll be so impressed with all the information they're getting out of it. And they'll also be impressed with the deficiency of information in a regular dental X-ray set of X-rays. And so even if they don't do the surgery, the implants, the bone grafting, all the different things that the cone beam is used for, they will be they will have a hands-on contact with that initially,
Right.
as they diagnose it thoroughly and refer it out of their practice. And somewhere in the back of their minds, they're going to say, you know, I think I'd better start learning how to do this myself instead
Right.
of referring it all out. And this is treatment that not only financially is detracting from my bottom line, but my patients would rather have me treat if I can do it successfully and competently. They would rather stay in the practice. And
Yep.
so all of this works to help that doctor make that decision. So ImageWorks is just fantastic. I love working with you. The support, mainly Melissa, my front desk, is the go in between person that handles the
Yep.
connections, and
Yep.
she's so happy with ImageWorks, and she's just
Great.
it's great.
Great. Well, I appreciate that. In a given month, I mean, just roughly, if you're comfortable sharing it, if you can't, no problem. But like, how many scans would you, on a typical month, do you think you're taking? 3D scans.
Good question. I don't know. So, you know, sometimes we're doing, you know, we can go a day without taking it, or we can do, you know, 3 or 4 in a day.
Gotcha.
And the thing is, you do a scan, and it could be months and months of treatment out of one scan.
Right.
It's just amazing. You get someone comes in as a new patient, and you don't want to bombard them with everything, but they're so deficient in their health care that you have to. And as you go through that, you know, you look at the scan. The one person I think of offhand, I mean, he needed probably 7 root canals on top of
Wow.
everything else that we have to build.
Yeah.
And you have to present it in a total package to give them an idea of what condition they're in and which way they want to go.
Yep.
Because they may like, yes, I want to save it. I want to work to save all these teeth, or no, I don't have the money. I'm going to go a different route. But at least it gives you that direction early on. So it's vitally important. I don't have any numbers with me, but
Yeah.
I'm so happy that I have the cone beam, and it's
Yeah.
you know, you could probably use the argument that you should do the cone beam on every person that walks in, and that wouldn't be a bad argument.
Right.
I'm probably a little more conservative on that, but before long, they're going to probably get a cone beam because I need to know what's going on.
Yeah. Yeah. There's no right answer. I mean, there's definitely, you know, depending on the specific practice, but I will say more and more we're hearing, you know, it's becoming part of that normal new patient routine. And you know, I think for all the reasons that you just mentioned.
Right. Yeah, it gets bolstered by the fact that we're picking up, when we do a cone beam, we're picking up so many things that were asymptomatic,
Yep.
unbeknownst to the patient, and all of a sudden there's something there. And so they're trusting us to diagnose. And as we see that, as that gets reinforced and we encounter that more and more, we're more prone to use the cone beam prophylactically.
Yeah.
Just to diagnose and find out what's going on.
Yep.
Because, you know, what we see when we see an FMX and it looks clean, well, it may not be that clean.
Yeah.
Just don't. Yeah.
Absolutely. Well, that's wonderful. Well, is it worth maybe shifting over and seeing maybe if we could look at a few things you wanted to show?
Here we go. Okay. This patient presented with this tooth, 18, lower left second molar,
Yep.
with changes in the bone, but the main thing is he had a buccal fistula. Okay, so he's got a buccal tract draining out, and you can see there's some change here. Then I wanted to run the cone beam on it, and this is what we saw in the cone beam. Let's see. This is the tooth here, and
Wow.
this is the one that's gone. There's the buccal out, drag this through, and you can see the infection all the way through to the lingual. So it's all the way through, back and forth, both sides. And this is how it looks on this side over here. And the 2D picture didn't show this at all.
Yeah, that's amazing.
This is major. So we, you know, obviously when I treated this case, I had to build up both sides and put guided tissue resorbable membrane and try and preserve that entire ridge, buccal to lingual and height wise. So,
wow.
And he's just healing right now. So he's hopefully doing fine.
Yeah.
And let's see. I'll show you.
And that's a symptom. And was this one of the examples where the patient was asymptomatic?
He was asymptomatic except for drainage.
Okay.
And so he, you know, that he did have some symptoms. It drained, but other than that, we never would have, noticed anything. Let me get another one here. Let's see. Okay, this is looks like it's tooth number 9, maybe 10. I can't recall offhand here.
Yep.
He's missing 11, and 12 is in 11 space and rotated or something. But here's some, off this picture, we've got some internal resorption going to an external site and starting to blow out. And I just wanted a clearer picture of it. So I ran into the cone, ordered up my cone beam. And there it is right there.
Yeah.
That site, and you can see if I can get a better angle on this. Yeah, you can see it blowing up there.
Wow.
And you can see it out there.
Yeah.
And so this was interesting because actually I said there's some, and he didn't want to lose his tooth because it's hanging onto a bridge, supporting his bridge, and he's not really young, so he said, "Can't you do anything to make this work?" And I said, "Okay, well, there's several things we can try." I said, as you see on the screen, I said, this is really, let's see. Yeah, there wasn't much. This was almost a separate piece. And I said, ideally, I'd love to use the laser, go in here and root canal to the end, but I don't think I can. And true enough, I got the instrument in there all the way to the end once or twice, but it's like shooting through an open space and you can't get it. So I said, let's be safe. I'm going to send this over to my colleague and endodontist who also has the laser and see what he can do. And he couldn't do the very end either. He just sealed up to here and he cleaned this out as best he could. And he said, if anything else, we'll have to go back. We'll watch this. And if it becomes a problem, we'll have to go back in and do some surgery. Okay. And so far we're watching it. It's asymptomatic. And if it stays quiet, that's great. But this sure allowed us to get a much better look at what was going on with this tooth.
Yep. And is it fair to say what it sounds like? I mean, the patient wanted to hold on to the tooth, and it sounded like this gave you options to try to extend that tooth.
Yes.
Longer than maybe what you would have been otherwise had you not had the information.
Yes, most definitely. There's another case. Okay, here's one patient. It's not real distinctive there. You can see it could be something, but obviously it was enough to make us suspicious. So we ran a cone beam on this. Okay, here we go. And there's that tooth. You can see this. That tooth has the bone loss around it, and then we'll just open this up a little bit. And then you just get a good picture of it. And it makes it real obvious. And it's just so nice. You can take this case or any case, and you're worried about a root canal, and you take other pictures. The PAs sometimes just won't show you enough because it all gets compressed. Right. And it makes it so much nicer for the doctor.
Yep.
And absolutely. I'll show you one last case that was really pretty neat. Let's see if I can close this all out. Okay, I just wanted a better picture of this tooth. And to make sure nothing else was going on. So we did the cone beam. Fortunately, I looked at the cone beam because he basically, as I recall, he was asymptomatic with everything. So let's close this down. And there's his infection here on that tooth.
Yep.
But the neat thing about this cone beam was I started looking around. This is the one that on his upper arch, I'm finding this big infection here. And I go, what? Because he was totally asymptomatic over here. And it turns out that this is part of a bridge that was just really breaking down. You can see over here too.
Oh, yeah.
And it had blown out. It had blown out around the palatal root and blew out the palatal aspect. This palatal wall is all blown out.
Yep.
So we had to section the bridge, take this all out, and then rebuild this ridge and rebuild the palatal part of the defect here.
Wow.
Since I was there, I had to build up this area also because in case we're going to put an implant in there. So this whole area has been built up now and it's just healing.
Yep.
But that, every time even my staff now, every time I run a cone beam, they come back and they go, what else did we find?
Yeah. Yeah. It's amazing, right? I mean, it's funny to your point of
They're
just thinking
everything.
how you would get this information with just 2D tools. It's hard to imagine.
Right. Let's see. Let's see if I have. See, this is how he presented with the regular radiographs.
Yep.
And it just really picks up probably the buccal root with the lingual root superimposed, and the bone looks fine, but it's all
Yep.
blown out on the other side.
Yeah.
Yeah.
I mean,
So,
yeah, the 2D, if you only had the 2D, you would have no idea that was going on.
yeah. And besides that, he was totally asymptomatic. He had no complaints, no mobility because it's all held by the molar here.
Right.
He had the stability, but wow, that was such a shock to find that one.
Yeah.
And but there was no problem explaining it to him because I showed him his case and he went, wow.
Yeah.
And fortunately for me, but very impressive pictures. So
To your point about imagine if the patient, a layperson who is asymptomatic, has no reason to think there's anything wrong. And if you just showed him the 2D radiographs, even if, let's say, you were aware there was a problem as the dental professional, it's hard to convince the patient, yeah, no, you should really take care of this because this is bad.
yeah, looking at the 2D picture, especially for a layman, he would say, I don't see anything wrong with that.
Right.
Looks fine to me. And
Right.
yeah, it does not look that bad on a 2D picture. So yeah, just kudos to you for your all your work with ImageWorks and allowing us these great instruments for diagnosis and just helping us with our treatment plans and treating our patients. I truly appreciate all of that.
Yeah, well, Dr. Louie, again, I appreciate all of your support. This has been incredibly valuable.
Oh, well, thank you, Don. I'm just happy to help. And again, like I said, thank you for this nice relationship. And
Yeah.
I know Melissa up at my front desk just loves the communication and support she's getting. And
Yeah, well, no, we appreciate that.
I work with this all the time, and I think you guys are great.